This is a quick review of bronchiolitis. What are the risk factors of bronchiolitis? Prematurity, heart and lung disease, especially congenital heart diseases, immunodeficiency, neuromuscular junction disorders such as myasthenia gravis, and age younger than 6 months. Remember, these are mainly associated with severe bronchiolitis and the possibility of developing or progressing to respiratory failure. That's a fatal complication. In what age it's commonly seen? In children younger than 2 years, and again in winter and cold seasons. Describe the natural history of clinical findings in bronchiolitis. Think of it simply as an upper respiratory tract infection that complicates into lower respiratory tract findings. So in the days 1 to 3, we have low-grade fever, rhinorrhea, and cough, even though young infants could have apnea at this initial phase. And then after day 3, from day 4 to 6, we have respiratory distress with risk of complication to respiratory failure. So we may have also tachypnea, hypoxia, accompanied by both wheezing and crackles. Now, what is the most sensitive sign of transition to respiratory failure? What is the most sensitive sign of respiratory distress? Tachypnea. After tachypnea, then we could have other findings such as grunting, retraction, hypoxia. How the breath sounds are described. They are resembled to washing machine sound. True or false? Diagnosis requires viral culture and imaging confirmation. That's false. Presence of noisy breathing in a child younger than 2 years in the winter with the progression of the symptoms, as I mentioned, is enough for making the diagnosis. However, when chest x-ray is recommended, when we are dealing with severe presentation and we need to rule out pneumonia. In that situation, what are the chest x-ray findings? We have bilateral interstitial infiltrates, bronchial thickening, diaphragm flattening, and even possible atelectasis. What's the most sensitive and most specific test? Nasopharyngeal aspirate for viral respiratory panel. That shows the most common pathogens. What are they? The most common one is respiratory syncytial virus, but other pathogens could be involved, including influenza virus, parainfluenza, metapneumovirus, and even mycoplasma and chlamydia, the causes of atypical pneumonias. True or false? Initiation of treatment requires nasopharyngeal aspirate testing for RSV. That's false. This gold standard test has no bearing on changing the course of management, as most patients require supportive care, or if more severe, some levels of short-acting bronchodilator. Describe the treatment of bronchiolitis. All patients are treated supportively with oxygenation, hydration, and suctioning. I mentioned bronchodilator is considered. What are the indications for bronchodilators? If the patient has the severe manifestation, or it's the first episode, or in the kids with history of asthma, we use bronchodilators. Another indication is positive family history of asthma. Now, what is the rule of bronchodilator therapy in management of bronchiolitis? We need to see if the patient is responsive to bronchodilators, otherwise we do not continue use of bronchodilator therapy. True or false? We can also try some other asthma management such as corticosteroids. That is false. We do not use asthma medications such as leukotriene inhibitors or corticosteroids. True or false? Heliox could be considered for the supportive care and treatment. That's false. True or false? Palivizumab is used for the severe cases. That's false. It's only used prophylactically when indicated. True or false? Ribavirin is the drug used for the severe cases. That is false. When do we use ribavirin? For the immunodeficiency patients with bronchiolitis. What's the other indication for ribavirin? Presence of underlying heart or lung disease, such as congenital heart diseases. Once more, in otherwise healthy infants without immunodeficiency or underlying heart or lung disease, we do not use ribavirin, and we do not use palivizumab for the treatment. It is solely used for prophylaxis. Describe the method of prophylaxis by palivizumab for prevention of bronchiolitis. When the kid is younger than 2 years of age and belongs to the high-risk groups, we use palivizumab in the winter or fall as prophylaxis. Now, what are the specific risk groups which are candidates for palivizumab? Again, patients with underlying chronic lung or heart disease, especially congenital heart diseases. Second group are the premature infants who are younger than 29 weeks. Third group are the kids with immunodeficiency, and fourth group are the kids with high risk of severe complications such as respiratory distress and apnea. Who are exactly this last group? Who are the people who have a specific risk of apnea or respiratory distress in the absence of other risk factors? Infants younger than 2 months of age with bronchiolitis are known to have much higher risk of complication into respiratory distress and apnea, and therefore they are the fourth group of people who are the candidate for prophylaxis with palivizumab. Summarize the step-up approach for the treatment of different severities of bronchiolitis. As I mentioned, we begin with the supportive care with hydration, oxygen therapy, and suction. Then we add bronchodilators in patients with history or family history of asthma, first episode or severe manifestations. And if the patient contracts the respiratory distress, we begin with consideration for intubation as the final management. For the patients with underlying lung or heart disease and immunodeficiency, the treatment is ribavirin. For the patients who belong to one of the 4 high-risk groups, we use palivizumab for prophylaxis. The last question is, I mentioned bronchodilators are indicated for patients with severe manifestations in addition to first manifestation, first episode, or history of asthma. What are these criteria for severity? Well, logically, any manifestation of respiratory distress beginning with tachypnea, but especially retraction and change of activity level or mental status, then very important is dropping or low levels of O2 saturation, and then, as I mentioned, infants who are younger than 2 to 3 months of age. Finally, pre-existing conditions, especially cardiopulmonary disorders, or presence of consolidation or evidence in support of pneumonia. These are considered the severe presentations. What else in addition to bronchodilator is needed? Well, patient needs to be admitted if they have any of these severe presentations. And as you can see, many of them are also making the patient a candidate for treatment with ribavirin if immunodeficiency or underlying disease comorbidities are present. Now, I would like to finish this episode with what I started, and that was the most sensitive index of respiratory distress, and that's tachypnea. Tachypnea does not have an absolute number for all ages, so we need to know the relative normal range of respiratory rate per ages for children, and in our focus here is our infants. So what is the normal respiratory rate for the kids younger than 2 months, the group that is the high risk group? And if we are on that group, we require specific management. Respiratory rate should be less than 45 per minute. How about in 2 to 6 months? Respiratory rate should be less than 43, and from 6 to 24 months, respiratory rate should be less than 40. So remember, up until age 2, if a kid breathes up to 40 breaths per minute, that's not considered respiratory distress. And with this, I finish our discussion of bronchiolitis.